Thank you, Andre. Wow. Well, I know many of y'all have known me for over 20 years, so y'all are like, what? It's good to see familiar faces. And thank you, LCU, especially Dr. Long and the research department, for allowing me to share our research that we did at Covenant. Very important part of this is to really talk about what we found and really not only take it from that point, but what are we going to do about what we found and what are the solutions and where else does this lead us in management? So one of the things that I was honored to do was participate in a multi-site trial. It's a national research study called the STAR2 Plus Network Study. The plus meaning we were the third phase of the STAR2 trial. And it was a trial looking at the engagement of frontline nurses. And so some of the background of this is that I received an email from Dr. Alexia Green, and I don't know how many of you know Dr. Green. She's well known across the state of Texas for her work in nursing. I call her the Florence Nightingale in Texas of nurses because everybody knows Dr. Green. But Dr. Green had forwarded me an invitation or an opportunity to participate in a multi-site trial and asked if Covenant was ready for this. At the same time, Dr. Long also was thinking that Covenant may be ready for participation in the same trial. And so really what an honor to have two different institutions of academia looking to Covenant and saying, are you guys ready for this? And we think you might be. Can we talk about it? So what I did with that email is, before I called Dr. Green and Dr. Long back and had some dialogue, is I reached out to Karen Baggerly, the Chief Nursing Executive at Covenant, and Dr. Marguerite Fallon, the Chief Nursing Officer at Women's and Children's, and said, can we talk about participation in this research study? And so together, Dr. Fallon, Dr. Long, Dr. Ford, and myself and Karen met to decide if we felt like we had the capacity at Covenant Health to participate in our first true research study at the national level. And one of the reasons I really did have to talk to them is because it was a $5,000 fee for participation. And so part of that was just figuring out, did they feel like we had that capacity and are they willing to support us in doing that? And so you can see Dr. Crenshaw, you may not know, at the bottom with Dr. Long, who was also my faculty advisor on this project. So what is the STAR2 trial? What does it stand for? Well, STAR is an acronym, and the acronym stands for Small Troubles Adaptive Responses. And it's Frontline Nurse Engagement and Quality Improvement. And on this national map, you can see all of the facilities that also participated in the STAR2 trial. And you can see Texas had quite a few, but there was nothing up in the West Texas Panhandle region. And really, I don't see any sites in New Mexico. And so when we reached out to ISRN, the Improvement Science Research Network, housed in San Antonio at University of Texas, we submitted an application to participate, and one of the reasons we got selected, we were told in our acceptance letter, was really our academic collaboration with Lubbock Christian University. That was a huge part of why they felt like we were ready to and an appropriate site for participating in this trial. The co-primary investigators at the national level for this research were Eileen Ng. She actually is a pediatric nurse. She's an acute care nurse up in the Washington, D.C. area, because Dr. Kathleen Stevens, the other primary investigator, is academic, and she really wanted this study to be co-led by an acute care and an academia nurse, which really mirrored our relationship at Covenant Health with Lubbock Christian University. And so, as we looked at small trouble adaptive responses, one of the unique things about this study, and really one of the unique things that Dr. Kathleen Stevens did, was she designed the first virtual network research study ever done in the world. Basically, she decided that research is so complicated, it takes so long to plan it and develop it, and you have to have some rigor behind your protocol and lots of reliability and validity testing for what your data collection methods. And so she wanted to make it easy for hospitals to participate in her multi-site trial, and so she decided that it would be great to do a first virtual network study. And so it was all online, it was all supported with phone calls, and when I wanted to go to San Antonio to get my data, she's like, well, nobody's ever come in person to get their data. What do you want to do here for your data? But it was real unusual because everything was done virtually on the internet and or over the phone. So why did we want to do this, and why did I think it was time for us to participate in this at our healthcare facility that I work at, is really the study was looking at how nurses respond to barriers in their care, workflow barriers. And basically, workarounds is what we usually call that. Our answer to a barrier is to develop a workaround. And as leaders, this is one of the studies that had a very unique way of looking at how to identify and capture those barriers we face in practice as bedside nurses. It allowed us the opportunity to be change agents and think of our hospital or our healthcare as a system, and at the macro system level, and understanding that it's a complex system, and if we change one thing, we're probably changing 6 others downstream at least. And to be a consultant with our academic partners and research partners at Texas Tech, Lubbock Christian University, and University of Texas through Dr. Stevens. So there were some unique terms used in this study, so I really want to start out by giving you some of the definitions because I don't want to lose you in the nomenclature. So one of the key things that this study does is it talks about the frontline nurse, and basically by definition, the front line is where the care is delivered. That's the interface with the patient and the clinician, whether it be the physical therapist, the occupational therapist, the physician, the nurse, but that's the front line. And that term was introduced by Dr. Tucker, and Dr. Tucker actually has a doctorate in business administration from Harvard and did her doctoral work in the early 2002, 2003 time period on hospital systems, and she really wanted to look at hospital systems and systems failure and coined that term, and Dr. Stevens based a lot of her work and used a lot of her terms from the seminal work done by Dr. Tucker. And process failures is a term that's used a lot, and that's barriers to completing tasks. That term was really coined by Dr. Don Berwick and his systems research that he did. And he was the first to think of healthcare as a macro and micro system. And so he has coined the term, and Dr. Stevens adopted it for this study of process failures, which basically a process failure, I need something I don't have to complete what I need to do. So if I need to put in a Foley catheter and I don't have a Foley catheter to put in, that would be a process failure. Or if I need to get an order from a physician and a physician doesn't call me back on the phone, that's a process failure. So it's not having the people or the stuff, the actual items to do your job. Organizational system failures are designed as indirect failures involving management, culture, protocols, processes, transfer of knowledge, and external factors such as roadblocks and delays. Really, if y'all came to hear Dr. Stevens talk earlier this week, I think that was just yesterday, it's been a long week, she said that an organization is designed to get the results that it gets. It's all in how we design our healthcare system, and so really organizational system failures are really how we designed our system that lead to error. And you can see those throughout organizations where there are roadblocks and delays based on how we've designed either its policy or EHR or processes. Operational failures are defined as the inability to provide information, services, and goods when, where, and to whom it's needed. These are the problems. And this is really where this study focused, was capturing the problems faced by bedside nurses at Covenant. First order problem solving was defined by Dr. Tucker and used again by Dr. Stevens in this study to really describe the typical healthcare professional's behavior of working around any encountered issue without doing anything to prevent it from reoccurring. Very interesting research findings around workarounds that I'll talk about here in a little bit. So background, of this is that process failures are faced by us every day in the jobs that we do. My research team called me out on this. There was one day I was meeting with my co-investigators, which 3 of them are staff nurses, and in front of Karen Baggerly, our CNE, they're like, "You just did a workaround, Jamie." I'm like, "Thank you." But we do it all the time. We are really good at being innovative as nurses. In fact, there was one study where it showed nurses were the most innovative of all professionals. We know how to get the job done, and we will do whatever it takes to get it done. But really, when we face those, we're lacking that something or someone to get the job done, and we're going to develop a workaround to solve our problems. So system failures create barriers that lead to that first order problem solving or a workaround behavior. Operational failures are the problems of not having who or what we need lead to workarounds. And process failures are barriers to completing tasks, and those occur approximately once per hour per nurse. In fact, 95% of process failures are managed through workarounds. And through Dr. Tucker's work, she found that when a nurse encounters a problem, on the 3rd time, we accept it as normal. We will not repeat it. We start accepting it as part of our workflow and part of of what's normal. So when we get new people on board and they're like, "Why do you do it that way?" It's like, "Oh, well, you have to." And we don't have to, but nurses typically after the 2nd time, on the 3rd time, will have already developed that workaround and start seeing it as normal. Workarounds expose patients to increased risk due to medical errors, and they create inefficiencies in the care that we deliver. So why is this significant? I hope you guys all know the triple aim, the Institute of Healthcare Improvement's triple aim that really healthcare has rallied around, which is to improve the care experience of our patients, to decrease the cost of healthcare, and to really create healthy individuals. But newly introduced within the last couple of years in the literature is the idea of the quadruple aim. And the quadruple aim adds a 4th element to the triad of staff engagement. And it makes perfect sense for the quadruple aim to really be a supporting theory behind this work, because without staff engagement, you really, to me, can't have the best care experience. You can't have decreased cost. You can't have better outcomes. And without staff engagement, you really can't create better systems for us to deliver care in. So I felt like quadruple aim was very important to tie into this project. It increases organizational and generalizable understanding. And because the burden on nurses can lead to burnout, disruptions in patient care, medical errors, and an estimated increase in mortality as much as 2%. So patients actually die from our inefficient care environment. For every 15 nurses working, the equivalent of 1 nurse is working and dedicating their entire time just to dealing with system failures. That's huge, especially for productivity, for management. And so it's important to kind of look at these system failures and see what we can do. So the aim of this study was to identify practice environment relationships with frontline staff quality improvement engagement in our surgical intensive care unit, our pediatric medical surgical unit, and in our oncology units. Those units were specifically selected by Ms. Baggerly, who is the Chief Nursing Executive at Covenant. And primarily what I asked her to do for me is we wanted to identify the units that didn't really have the best care, but didn't have the worst care, because we wanted to avoid the ceiling effect or the bottom effect, and we really wanted a true representation of how care is delivered at Covenant and the workarounds our staff are encountered. So we really, not that that's easy to say or do, but tried to really find some units that were truly representative of the average care that a nurse would face at our system. And one of the things I didn't know till we submitted this and as our units was the ISRN came back to us immediately and said we would be the first pediatric and the first intensive care unit participating in the STAR 2 trial. And so Dr. Stevens was really excited about that we would be giving her some data from some unique nursing areas that no one else had given her. I was like, oh, okay. I was like, we didn't do that on purpose, but it was really nice to be able to say that. And I think the SICU nurses, that really helped with buy-in. I'm like, y'all are the first. The purposes of the study were to describe the type and the frequency of first-order operational failures. Those are those problems that they face. And to describe the workaround impact on nursing frontline engagement and on the work environment. So in the literature, it was very hard to find a lot of literature in our peer-reviewed journals on system failures. And so I chose to really focus my literature review on workarounds because there's a lot of research that's been done around nursing workarounds. And the operational failures that we see that lead to workarounds really influence are caused by organizational influences, disruptions in workflow, and even social factors, how we raise our new nurses or introduce them into our care setting. One of the things is nurses typically work in crisis mode due to high acuity and fluctuating workloads and productivity pressures. So we don't necessarily have time to try to find a solution to workarounds. There's a mismatch between newly adopted technology or policies and current workflow. In fact, the number one cause of workarounds today is technology in the literature, and you will see that is true of our institution as well when we look at the results from our study. Poor communication and coordination of interrelated tasks between interdisciplinary team members to avoid confrontation or due to etiquette, or dismissing nursing opinion regarding care of patients also leads to problems in the patient's workflow, the nurse's workflow in taking care of the patient. Some of the ethical considerations that were taken into account were that no participant identifiers were collected. Every nurse was assigned a random number, and every unit was assigned an anonymous number, so it de-identifies what data came from which units and which nurse participated in the research. The Institutional Review Board designated it exempt by the study site, and by the study university, it was designated as expedited by the IRB. The framework is very interesting. I know that Dr. Stevens talked about the complex adaptive system, or the CAS framework, yesterday, but she didn't really show the picture, so it's kind of nice to be able to show you this picture. But she talked about how we work in a dynamic work environment, and again, when we make one change, it affects other people, it affects other processes. And so even if it's something like central supply running out of a piece of equipment that we need to do our job, that impacts our charge nurses, our unit clerks trying to get that supply, the nurse at the bedside trying to do that procedure without the proper supplies. I mean, it impacts a whole group of people, and so it all kind of changes the environment, and it's ever-changing organizational at the unit level as well as the organizational level. And so we see that in our culture, our structure, process, and outcome can really be impacted by the systems that we design and truly impact the frontline staff delivering the care. And the design of this study was a prospective cross-sectional multivariate quantitative research study. And the setting was an 881-bed acute nonprofit tertiary care hospital in West Texas, who employs over 5,000 employees and serves 62 counties. So the nurse demographics, the only reason I have the organizational demographics up here is this is what we submitted to ISRN in our application to participate in this study. And so I've had some of the nurses at our organization go, really? But if you think about the average nurses in each unit, you have to remember we have like interventional radiology, we have some subunits that are hemodialysis that are smaller, but the average number of nurses on each unit is 13.14. I was surprised by the number of male nurses and the disparity between the female and male nurses at Covenant. It just seems like there's so many more men in nursing today, but at our institution, we only have 187 men, and we had, at the time, 1,140 women. Full-time RNs made up the majority of our nurse demographics. We had 80 part-time registered nurses and 80 per diem registered nurses. The ethnic distribution surprised me a little bit as well, and I don't know if it surprises you guys or it's just me, but of course Anglos comprised of over 70% of our nurse population, Hispanics nearly 15% of our population, Asian or Pacific Islanders a little over 9%, Black or African American only 3.77%. I really don't know who fell into the other, but we had some that classified themselves as other, and then American Indian, and then not available on some of our nurses. So this is the makeup of our organizational nursing staff. The sample of the units that we selected, we did select the units for the research project at the unit level and not at the individual level. So the units were selected first, and then every registered nurse was invited to participate that worked on any of those units. So again, Unit 1 is a 32-bed unit, Unit 2 is a 35-bed unit, and Unit 3 was a 17-bed unit. The average patient length of stay, days-wise, on Unit 1 was 5.53, Unit 2, 3.96, and Unit 3, 4.75. The average patients for each nurse ranged from 2 to 4.75. The number of full-time registered nurses in the units ranged from 24 to 67. And the number of part-time registered nurses ranged from 1 to 4. There were some per diem registered nurses working in those units. And then the average number of medications administered in a day was calculated by our out of our Pyxis report for those units and averaged out. And Unit 2 had an average of 75 meds administered per day compared to the other two that were pretty comparable of 301 and 257 meds per day. So the variables measured. When we talk about research, I said one of the things we wanted to measure, we wanted to capture those failures, those process failures. But the other thing we wanted to do is tie the process failures to the work environment of the nurse. So this really was a two-part collection, data collection tools. So the first part was the pocket card, and I tried to hand you all out a pocket card. It's the little green card, and we'll talk about it and see it again in a minute. But that's the card that was used to capture the frequency and type of operational failures our nurses were facing. The other variables that were measured were measured using a survey packet that measured team collaboration, hospital staff opinions about patient safety issues, medical errors and event reporting, work environment, the volume of quality improvement activities, quality of care, and the overall job satisfaction. And you can see that all of those were measured with sound measurement tools that are known to nursing science that are currently used today. The other advantage of some of those tools is they made it where we could benchmark our hospital against other healthcare facilities because they are readily available and well-used tools for measuring those variables. So what we did was we delivered the pocket card and had it available to nurses on the 3 units for 20 days and a maximum of 10 shifts per nurse. So they had 10 cards and they could choose to participate or not participate. We introduced it at staff meetings on all 3 units. And then after the 20-day period, day 21, I distributed the survey packet into each of their boxes on the unit. I did try to go around and do reminders and flyers, and the survey packet takes about 30 minutes to complete all of the surveys. It did not have to be completed in one sitting, and they could return it back into the locked collection box within 1 week. So this is just an example of the data collection pocket card and how a nurse may have filled it out. Here you can see that what we asked them to do on the back side of that card, it gives them examples of things that maybe falls under equipment and supplies, physical unit layout, information and communication, staffing, training, and or medication. the nurse could plug in their problem to whichever category they felt like it fit. And as I recorded the collected data, I didn't move it based on my opinion of where I think it fit. It was all left where the nurse felt like it fit as they recorded the problem and in their exact words. If they encountered the same problem a second time during that shift, they would record it with another tally mark. And so they could record the same problem as many times as they encountered it in that one shift. And actually the air conditioner making a loud noise was on one of our return surveys, and I'm like, okay, well, that impacted nursing that day. Physician not returning a page. So anything that they encountered, we asked them to record them all. It was only for registered nurse participation, but I did not want any of the licensed vocational nurses to feel excluded. So basically, I just let everybody have cards, and I just disregarded the LVN cards when I was inputting the data. I felt like that was probably easier than trying to explain to an LVN why they don't get to participate and an RN could. So that was my personal choice on how to handle the patient sample of only being registered nurses. The data analysis used was descriptive statistics, t-test, and one-way analysis of variance, or ANOVA. Resources, I told you it was $5,000 to participate, but what did you get for $5,000? Now this is where I think what Dr. Stevens has done is very unique, because she had already developed the research protocol. She already even had the IRB application pretty much typed for you. It was just a lot of copy and pasting and getting it through. So really all of the hard work was done by the ISRN at the University of Texas. And so we got all of the tools that allowed us to do it. So those of us without a PhD background could still do quality research that still had the rigor behind it that we would see coming from a PhD prepared nurse scientist, and in an acute care setting where very few PhDs live in our world. It included that IRB guidance, like I said, and even support. So if I had trouble getting it through our IRBs or needed anything, they were always there. It included webinars for how to enter our data. There was a webinar on the study itself. The expert guidance, just everybody was available, a phone call away from Dr. Puga to Dr. Stevens, just unbelievable support. Bi-weekly progress meetings and very, very generous faculty and staff that work with Dr. Stevens. The technical protocol implementation guidance, every tool we needed was just given to us. They mailed the survey packets, they mailed the green cards to us. They mailed implementation kits. They even mailed the reminders to turn it in. So I had everything handed to me, even the flyers of, hey, don't forget to turn in your survey. You've got 3 more days. And then the protocol implementation kit. So looking at the results, what did we find in our 3 units? Well, in our pocket card data, we had 54 nurses that participated in the study, and only 5 nurses completed both the pocket cards and the nurse survey. Now remember, the goal of this study, or the aim of this study, was to look at the correlation between quality improvement and problems that they encountered. So really only 5 people out of 54 contributed to the great vast network study. But again, it allowed our site to give 5 participants input into the bigger picture of nursing across the United States. So not to minimize that, but the question is, why didn't we have more nurses participate in both? And one of the answers may be survey fatigue. Maybe they feel like if they participated in the pocket card for 10 days, they didn't really need to do the survey. I mean, nobody told them why we wanted them to do both necessarily. It's just like, here, could you complete this? And so, again, we had only those 5 that did both, but we had 54 in all that participated. So on Unit 1, we had 29 participate in the pocket cards, 9 participate on Unit 2, and 16 on Unit 3 for a total of 54. The day shift, we had 27 participate on Unit 1 compared to 19 on their night shift. Unit 2 was split down the middle, 4 and 4. And then Unit 3, we had 22 on the day shift participate and only 4 on the night shift. Everybody, 100% worked 12-hour shifts on every unit. Survey responses that we got 7 surveys back from Unit 1, only 1 survey back from Unit 2, and 5 surveys back from Unit 3. And so another thing looking at this data that you hopefully are asking yourself is, why was there such a low participation in Unit 2? Because pretty much participation in Units 1 and 3 was pretty comparable, and even the further results are comparable, but Unit 2 seems to be an outlier with participation and some of their results that we saw. In all, we captured 428 operational failures through the pocket card reporting in a 20-day sampling period. 480 hours were captured of nursing failures with a failure rate of 0.89 per hour. That's 10.68 failures per 12-hour shift in our hospital. Now that really does kind of match up with Dr. Tucker's findings of about 1 problem per hour per nurse encountered in direct patient care. The frequency of operational failures that were captured that you see here, you can see it divided again by Unit 1, Unit 2, and Unit 3. But when you look at all of the units, you really see the highest number or highest percent was equipment and supplies at 35.51%, and there were 152 operational failures captured just in that one category. 428 total, but then you look at second would be medication and other at 81 operational failures per each of those categories. So those are the top 3 categories where we found problems. Staffing and training didn't seem to be as much of an issue as equipment, supplies, medications, and other. When we looked at those categories and compared the units, again, you can see here, these are the reports, categories of operational failures by nurse. And so the first category, this blue, red, and green, are the equipment supply failures reported. You can see the majority of those were reported by Unit 3. But again, Unit 2 and Unit 3 throughout all of the data are pretty much comparable. And again, Unit 2 seems to be our little outlier there in the middle in red. And in most all categories. And you can see kind of down the category list how the units compared to each other and the average number of operational failures that they found. Now the survey packets, this is looking at each survey that was in the packet, 1 survey at a time, and the results of each of the surveys. So the first survey they took was the Agency for Healthcare Research and Quality Hospital Survey on Patient Safety Culture, or the ASOP survey. And I feel like that we really had very good results. We had no survey failures that were rated low on any of the survey items, but you can see the highest being that of teamwork within units. So our facility, our nursing staff feels like they have great teamwork. Supervisor manager expectations and actions promoting patient safety. That's a common theme throughout all of the findings in this study, and the patient safety grade. So I think as a nurse leader in the system that those are great things to score very high in. The lowest score, or the frequency of events reported, is the lowest of those, and then followed by teamwork across units and handoffs and transitions, which kind of go together anyway. So although they like the teamwork on their unit, they're not necessarily feel like that they've got that across units or during handoff of care. This is the second survey that was combined in the survey packet, which is the Practice Environment Scale of Nursing Work Index, the PES-NWI. Here you can see Unit 1, Unit 2, and Unit 3 looking at nurse participation in hospital affairs, nursing foundations for quality of care, support of nurses, staffing and resource adequacy, and collegial nurse-physician relations. Here, there is no standard error for Unit 2 because we only had one survey turned in, so we can't have that for that unit. But you do see the standard error for Units 1 and 3 reported here. 1 was a strongly disagree, and 4 was a strongly agree. And so as you look at the mean here, you can see that we kind of hovered between disagree and agree in the mean across the board, with the lowest being in staffing and resource adequacy and the highest being in nurse participation in hospital affairs. And so this survey tended to demonstrate the lowest results of any of the surveys that were combined in the packet. The Healthcare Team Vitality Instrument, or the HTVI, looked at and measured support structure, engagement and empowerment, patient care transition, and team communication. Again, we don't have any standard error for Unit 2 because we only had the one survey, but you can see here 1 was strongly disagree, all the way to 5 strongly agree, so it was a 5-point Likert scale on this survey versus the 4-point on the survey before. And you can see, again, our mean scores in all of those units, the highest being in team communication. Again, that seems to be a common theme. They're really happy with the nursing teams on these units, but support structures scored the lowest, but really none of them were too terribly low, nothing really below average on this survey. Here are the outcome variables of individual nurse job satisfaction scale, the assessment of quality care, which was a global score, and quality improvement activities, which we had the nurses report just a number of how many quality improvement activities they've participated on their unit in the last 6 months. And you can see the individual nurse job satisfaction scores. 4 to 7 was medium and 8 to 10 was high. And the satisfaction average, or the mean, was 7.56. So fairly satisfied with the job and the work they do. The assessment of quality of care global score, 12 to 15 is high, and this institution on these 3 units scored high in this area. They do feel like we give quality care. Again, a common theme was quality and safety and teamwork were all up there with all of the assessment findings. And then quality improvement activities, I found this one very interesting because I know which Unit 1 is, but Unit 1 reported 17 quality improvement activities in a 6-month period. And it really drove the average up because there's an average of 5 per unit. And so Unit 2 only reported 2, and Unit 3 reported 2. And I admittedly, even myself, tried to figure out what 17 they were talking about but they're an amazing unit. They all are. But it was like, what are at 17? I mean, they have been piloting a few things, but that really did kind of skew the results on that particular variable that was being measured. So really, the discussion should center around a few things. Why did we have such a low response rate in one unit? And to be honest, I don't know. I had co-investigators that called that unit every single morning to remind them to participate in the STAR2 trial. We did call all 3 units on a daily basis because my co-investigator, Cheryl Colum, gets there bright and early, and I'm not a morning person, so she took on that role of reminding them for us to participate. And she would really get a negative attitude when she called this particular unit and not the others. I always felt a little uncomfortable and unwelcomed when I would go to the unit and check the data collection boxes. I tried to remind the nurse educator, the nurse manager, and I even reached out to the chief nursing officer to help with that unit. I don't really know. They may be less familiar with me than the other 2 units as the primary investigator because I don't work with them as often. So it could be a lot of things. Don't really know why that one unit had such a low response rate, but there was very little buy-in. Minimal participation in both pocket cards and survey. I try to explain that a little bit. Maybe survey fatigue. Y'all may have some ideas, Dr. Long, and why we would not see as many or the same people, because we had quite a few participate, but not very many participated in both parts of the study. but maybe survey fatigue. Maybe because it was a book, it looked like way too much trouble versus the little small pocket card that was easier to tally. But we did have low participation in both parts of the study. The moral obligation for quality improvement is there. As an institution, it is our job, or my job, because I found these deficiencies in our system. It's my moral obligation to work as hard as I can to fix the deficiencies that were identified. And I think that's part of the moral obligation when you do research on quality improvement failures, system failures, process failures, anything that may be negative, barcode scanning, medication errors. If you're finding the etiology of those errors, really it's our obligation to try to prevent that for patient safety reasons and staff satisfaction, obviously. We were looking at nurses being happy with their jobs and not having to work around so many problems. It is sustainable through the use of a pocket card, and very interestingly, one study looked at, and it was another study by Dr. Tucker later in 2005, reported that nurses will not write a system failure on a piece of paper or a failure log. You can have a paper log right by where they chart at every nurse's charting area, and they will not record their failures. But what I think I have found, and I think Dr. Stevens' work supports this, is nurses were very willing to carry a green index card in their pocket and fill it out for me, to the point where I still have SICU nurses going, "You got any more of those green pocket cards?" every time I walk up there. So it seemed to be a valid way to gather data, very low-tech way to gather data, but it seemed to be acceptable and easy for nurses to just carry that and be willing to report data in that way. Dr. Tucker's study there also showed that unless nurse leaders are there in the moment when they encounter the failure and we witness it and we're told it, we won't get told it later. You can round all you want, but they're not going to tell you unless you're actually present when they encounter it. So it really kind of pushes that moral obligation as nurse leaders to be more present in the practice settings so you can actually identify things that we can fix and make their lives easier as they deliver care. So I do think it's sustainable. In fact, Dr. Stevens said that her next goal is to allow facilities to continue to use the pocket cards to guide their process improvement, because it actually gives us data, real data, to guide our quality improvement efforts. So it's not me just saying, well, I think we need to work on this in my hospital because I see this, which is very anecdotal. When we have staff members saying, I'm encountering this all the time and I have all that data to back it up, that data should guide our quality improvement activities. So really it leads to evidence-based quality improvement, which I think y'all heard Dr. Stevens say as well, her new coin word that I learned last year in San Antonio. And again, staff engagement is a necessity. Nobody can fix a system failure that's encountered by somebody if you don't know about it. And so I see lots of leaders in this room, and you guys know that if you don't know it's bothering them or impacting the care they're delivering, how can we help them at that point? Conducting research can be done locally with centralized oversight. You can examine multiple systems at the same time. You can conduct research collaboratively if it's an investigative team rather than having one principal investigator. Virtual interaction across the investigative team is important as well. And I purposefully chose 3 staff nurses to be on my research team because not only did I want to increase a love of research in our nursing population, but it allowed them to participate in something really big, and I think it was very meaningful for all of them. It was life-changing for them to sit down with Dr. Stevens for 6 hours in San Antonio. If there was no other life-changing moment for them, it wasn't working with me, but the time that Dr. Stevens gave them and energized them and that dialogue they had was incredible. And so I really think we owe it to not live in a bubble and do our work in a bubble, but to engage people to join us in our journeys in research or quality improvement. And you're building capacity and you're passing that flame forward for these people to continue good work and to learn some new skills. They add skills to their tool belt that we all need these skills to successfully do many things. Limitations: it was a small voluntary sample from 3 unique units in 1 hospital. The nurse survey results only reflect one point in time for the participating nurses. The site data is not generalizable because of the fact it's one hospital and 3 units. The low response rate in 1 unit was a limitation, and limited participation in both the pocket cards and the survey. The implications for practice, and I alluded to this already, but results from this study will guide our institutional redesign to decrease the problems or those first-order operational failures that our nursing staff is facing. It leads to evidence-based quality improvement. There's a symbiotic partnership providing opportunity to improve healthcare by addressing the site-specific findings, and job satisfaction can be increased through that. Nurses will feel heard and their job gets easier. Of course, we're going to increase their job satisfaction. Our clinical outcomes can get better. Research says as many as 2% can die just from these inefficiencies in our systems. And so our clinical outcomes can improve. Our safety and quality, our productivity, and our patient experience, which all tie back to that quadruple aim. The study funding, study was funded by an NIH award from the National Institute of Nursing Research and the Robert Wood Johnson Foundation of Interdisciplinary Nursing Quality Research Initiative grants. And again, acknowledgement. I have to tell you that I'm humbled to have gotten to work with such wonderful people in this research journey myself. And this is the team of Covenant Health nurses together with the team at University of Texas in San Antonio. And you see, we did not plan it where it was every other person, but I find it interesting that every other person's one or the other. We made new friends. You probably saw that on Facebook if you're my Facebook friend, because Kathleen Stevens told them to show us a good time in San Antonio that night. But the first person in that picture is Dr. Frank Puga, who teaches at the School of Nursing at University of Texas. Francis Cortez, who worked on our neurology floor for Stephanie there in the back. Braulio, who is amazing. Braulio was the point person for myself, and he's the data expert really that Dr. Stevens leaned on for this study. Cheryl Colomb works in endoscopy lab. Kathleen Stevens, you see, and I must be taking the picture, I'm not there. And Aruna Maharan, who's a SICU nurse. She's just got into CRNA school at TCU, but she has recently left our organization, but Aruna's there as well. And it was just a vital team getting together and really learning about our institution. And again, other acknowledgments. Personally, for me, I made a new friend in Dr. Stevens that I will consider forever a friend. And I learned of a person that I will truly endear forever in a lifetime. As much as I endear Dr. Long, who I couldn't do anything without Dr. Long. She probably says I could, but I can't. Who agreed to work with a Texas Tech student on a project. Thank you. She does. She loves everybody. But she worked with my my doctoral advisor, Dr. Crenshaw, to help me get through this journey. Again, without the leadership of people like Dr. Long, that's a leader in research, and the leader in quality improvement like Dr. Green, who thought that our hospital was ready and had the capacity to do something like this, it would have never happened. And then again, you cannot discount the support of your executive team, because you do need resources for projects. And so the support of Ms. Baggerly and Dr. Fallon is huge, because not only did they believe that I could do a research study, which is enough belief in just little old me, but they believed that our nurses were ready and our organization was ready to be a part of something really big. And so I do have to say thank you to all of these people. Can't help but say thank you to my Texas Tech faculty that dried lots of tears and got me through a doctoral program, but guns up to them. I must have skipped a slide because I don't recall telling you what the 3 top findings were. And so I don't know if it's just not in the presentation or I skipped a slide. So let me tell you. The #1 operational failure reported in our organization was Meditech. Number 2 was pharmacy. And number 3 was connectivity. And it's all making sense now, right? I found it very interesting as an old nurse, because I've been doing this 26 years. Some of y'all have been doing it longer than I have around here. But as an older nurse, I guess that's what we'll call ourselves now, 26 years of nursing, who would have ever thought that 2 of the top 3 failures have to do with technology? The EHR that's supposed to make our life so easy, and connectivity, which I think they put connectivity under them saying it took a long time for Meditech to load. You know how when you get on a new computer for the first time and it takes forever? That's what happened to me in Bonnie's office yesterday when I was trying to pull up Dr. Stevens' stuff. Because it has to figure you out on a new PC for some reason. I don't know why, but those were our 3 top failures in our institution. And so I don't know if y'all have any thoughts on any of this research. Any questions, thoughts?
That is so interesting, Jamie. But I'm so disappointed about only 5 completing that. Is there something some reason you should not tell the people the importance?
Well, I really wanted to coerce and bribe that unit too. I don't know how many times I tell Dr. Joanne Long that nobody is participating on this unit. And I tried calling everybody that had influence over them in their nursing ladder. I know, I should call Larry to go over there. Larry, get them to do this.
Was it a busy time of the season where they were having to get extra staff to come on and work those units?
That was another thought process, is it might have been a busy time. It was in the winter, but if you consider we had flu season and RSV season on the adult and the pediatric side at the same time, it's hard to say if the respiratory viral season, if it was going to impact one of these groups, I would have thought it would have impacted all 3. Especially because we have such a late flu season in West Texas.
There's other issues with
And I don't know why, but the same charge nurse charged every single day I went to check on that unit. I'm sure she didn't work every day, but when I went every day she was working. And she really was not bought in, and that could be part of it as well. Because I think charge nurses are those leaders on a unit that truly make or break whether we succeed in our initiatives that we try to roll out.
It's interesting why any nurse doesn't do, we're going around begging people to take the employee engagement survey.
Yeah.
So it's just constantly trying to get them to, and maybe they just get tired of that. I don't know.
And it's not like it takes long, but I think once you've conducted or participated in research, you appreciate that participation so much more that there's no research or survey I get that I don't complete, because you really feel for people that are trying to learn from the rest of us.
Very, very interesting, because I've missed all of these that you've given around here and there, or I've missed most of it, and so this is the first time I've heard it all. It's very interesting.
Do y'all plan on continuing on the other units or some of the other units in the hospitals? Or?
Well, it's copyrighted right now as a data collection tool, but that's what Dr. Stevens was saying, is that she feels like her next move will be to release the pocket card for use to institutions. The other thing is, Dr. Stevens told me yesterday she just got her first article on the STAR-2 trial accepted for publication. And since we were the 3rd round, I cannot submit my manuscript until Dr. Stevens publishes this 3rd round. That was part of our contract between our hospital and ISRN, is we are not allowed to, and that's it's a good thing. I don't want it to sound negative, but we're not allowed to disseminate without letting them know we're disseminating their work. But in some way, I think that's their way of recording how many times and how many ways people are hearing about their research study. And then again, the embargo on any publications until the PIs get to be the first at the publications. I have written a manuscript. It's just waiting for the opportunity to be submitted for consideration for publication. And I did focus a lot of my background on workarounds in my manuscript, because I didn't know where to take it, because it's looking at systems, and I was like, well, I'll just focus on workarounds. Take lots of angles.
I want to commend you on just the great work that you've done. This is, it's a beautiful thing to see. This is the work of, of a DNP. And so we've got students in the room, and, that role is to do exactly what Dr. Stevens said yesterday, and that's quality improvement and evidence-based practice, but to make the change real. And I think as more of us, as we have a stronger, commitment to educating nurses and keeping them in clinical care, what's going to happen is care is going to improve. Because that's the whole purpose of this, is because there are patients that need us to reduce the number of workarounds. And their very life depends on our ability to do it. We don't think about it that way, but it's the truth. And if it's my grandson or me or someone out there, I don't want to work around. I want the real thing. And if we can just keep after it, all of us in this room, and remember that there's a patient on the other end that's going to maybe live or die because of whether or not we decide we're going to be engaged.
We were talking about that the other night at Orlando's, that so many of either the DNPs or PhDs work in education. And I think it will be so exciting when a lot of them work in the clinical setting. Can you imagine how that will change the healthcare setting to have more highly educated people? I just think that is so exciting. And I think we're going to see a lot more highly prepared nurses.
I think we're already seeing it, and even the posters in the lobby are better and better every year. I don't know anybody that hasn't seen improvement just even in the student presentation of evidence and research, because it just keeps getting better and better, and you're like, wow, this is good stuff.
It's
now
improving.
IRRs, and so I agree.
And our BSNs, the very fact that you're getting your bachelor's degree, I hope you know that 11 lives will be saved for every 1,000 of you that have a BSN. That's what the national data says.
Really?
Spoken like a true researcher.
No, isn't that amazing?
That is.
We don't think of our work that way, but it's true. Thank you for coming.
That's
Wonderful job.